Good afternoon. Welcome, everyone. We'll get started in just 1 minute. All right. Good afternoon, and welcome to this session on perinatal quality improvement during the COVID-19 pandemic. This webinar has been organized by MD Mom, a 5-year statewide maternal health program in Maryland, funded through the Health Resources and Services Administration's Maternal Health Innovation Grant. My name is Jennifer Callahan-Coru. I'm an assistant professor of public health at the University of Maryland, Baltimore County, and I am also a member of the MD Mom program that is organizing this webinar, and I'll be introducing our speaker today. First, some quick housekeeping information. Please note that this webinar is being recorded to be made available on the MD Mom website. We will also be taking questions at the end through the chat box, so please go ahead and put your questions there. You can put them in as we go along if you'd like, and then we'll have our speaker address them at the end. Now I'm delighted to welcome our speaker today, Dr. Deborah Bingham, Associate Professor for Healthcare Quality and Safety at the University of Maryland School of Nursing and founder and executive director of the Institute for Perinatal Quality Improvement. Deborah is a registered nurse with a master's degree in perinatal nursing from Columbia University and a doctorate in public health from the University of North Carolina, Chapel Hill. She has over 30 years of experience leading quality improvement in maternal and newborn healthcare, notably serving as the first executive director of the California Maternal Quality Care Collaborative, and is the Vice President of Research, Education, and Practice for the Association of Women's Health, Obstetric, and Neonatal Nurses. Currently, Deborah is an Associate Professor of Healthcare Quality and Safety at the University of Maryland School of Nursing, where she is advising the faculty on how to expand the utilization of implementation science and improvement science methods within the Doctor of Nursing practice curriculum. She is also a perinatal consultant and the founder and executive director of the Institute for Perinatal Quality Improvement. Deborah, thank you very much for being here today and for sharing your expertise on how maternal health providers can continue to ensure high quality care in the era of COVID-19.
Hi, everyone. It's great to be with you today. So if you have questions throughout the presentation, feel free to put them in the chat, and then I'll answer the questions at the end, unless there's something very pressing during the presentation that. Anyway, so I'll try to be monitoring the chat, but if I don't get to your question during the presentation, I'll definitely get to it during the end. So let me see. Need to forward my, oh dear. I had worked on this before. Oh, there we go. Okay. First up, I want to say that I hope your families are well and that you are well. I know these are really challenging and unusual times for all of us. I particularly want to honor and thank all of you for the ways in which you're working to ensure safe and high quality care for perinatal patients during a pandemic. And I also, with the murder of George Floyd and all of the other information that's come to light as we've been discussing more and more about racism in the United States, I want to honor and thank everyone who is willing to speak up against racism. It's definitely very important and something I'll be going over in the presentation. I think we need to all speak up, and I use Speak Up. It's an acronym as well as a mnemonic within the Institute for Perinatal Quality Improvement. I'll explain that a little bit later, but we all need to speak up, which includes acting against racism now more than ever. And that's why I formed the Institute for Perinatal Quality Improvement, which is working to expand the use of improvement science in order to eliminate preventable perinatal morbidity and mortality and ensure equity in outcomes. QI saves lives. And this is really critical to recognize that all of the ways in which all of the methods and tools with QI have shown to make a difference. In fact, the efforts that I helped lead and develop in California help bring about a 50% reduction in maternal deaths in about a 5-year period. This is important to point out because we all need to recognize that this work, QI, is very important. And back in 2006, the Hastings Center, which is one of our premier think tanks in the United States, the ethics think tank for healthcare, put together an expert panel on quality improvement. And they said QI is an ongoing process undertaken of the consequences of healthcare providers' responsibility to serve their patients' interests. And I often ask groups when I present is, whose responsibility do you think it is to lead and to participate in QI? And what do you think the answer is? Well, it's everybody. It's not discretionary. Health professionals, managers, delivery organizations, patients, government, all have an ethical responsibility to cooperate with one another to improve the quality of care. Well, during a pandemic, the gaps and chasm between what we know and what we do get even wider. But we also know that there's been, like, the data show us that, and it's old data, but I haven't seen any newer data to give us any hope, but it's at least a 17-year gap or between what we know and what we do on average. During the COVID-19, there's a gap, a big gap in what we know in order to guide what we're doing. We're feeling our way through this pandemic. And we need to be careful that in trying to prevent harm, we don't cause more harm. We can't ignore what we already know. And also we have another problem that we don't have a lot of knowledge. Clinicians have not had a lot of education around QI methods and tools. That's one of the reasons I work at the University of Maryland, is to expand that expertise among faculty and students. And we also have a lot of problems with getting data by race and ethnicity in order to help us understand disparities. So today what I'm going to talk about is I'm going to talk a little bit why perinatal QI is needed particularly. I'll mention some of the Maryland data, which you probably know. And then I'm going to focus in on what I think are three really big QI priorities. These are not the only ones that we need to focus in on, but I'm going to use them as kind of examples about how you can lead QI. You may have other priorities at your particular hospitals, but overall in the United States, one of the biggest priorities I see is that we need to increase vaginal births. We need to decrease and eliminate overuse of cesarean births. We also need to make sure that women are aware of, all women are aware of their post-birth warning signs. And we also need to keep moms and babies together. And I'll go through an example of doing how to use QI data, how to create QI run charts to help guide decisions during a pandemic. This slide shows us the trends in pregnancy-related mortality in the United States from 1987 to 2016. And as you see, it's headed in the wrong direction, and it's very concerning to me. I've been working during all of those years, and it's really kind of discouraging to see that my efforts have not had a big impact on the national data. So that's where we all need more partnerships and need to work harder. If we look at what are currently the leading causes of maternal deaths, I mean, this gives us a snapshot. There have been the same causes of death over many years, over many decades. Most of the causes of death, you know, there has been some shifting around the proportion of different deaths by cause of death. But typically the causes of death that are most likely to be preventable are hemorrhage, infection, thrombopulmonary embolism, and hypertension-related deaths. Anesthesia used to be one of the leading causes of deaths. That is a very big success story. They use QI to help learn and reduce anesthesia complications. Cardiovascular has become a larger leading cause of death. And then in pregnancy, associated deaths, suicides, and opioid deaths, or I would broaden that to say substance use disorder deaths have also been increasing more recently. We have huge disparities in the United States based on race, ethnicity, and these, we can see that Black non-Hispanic women have the highest rates of pregnancy-related deaths in the United States, 3 to 4 times more than white women or Hispanic women, and then Indigenous, American Indian, Alaska Native, non-Hispanic women also are disproportionately affected. So this is, to me, completely unacceptable, and it's really important and a serious obligation for all of us to work to understand our contribution to these data, and then work to eliminate whatever's leading to those disparities in our data. We also have seen over a 200% increase in severe maternal morbidity in the United States. Most of that rise has been related to additional use of blood transfusions. So the question becomes, we know that a lot of the hemorrhage-related deaths are because women don't get blood early enough or don't get enough blood. So to me, the question is, why has there been such a rise in the need for blood transfusions? And a lot of that has to do with overuse of cesarean births. I looked at the Maryland data, and it's so just because I think primarily people on this call are in Maryland. And unfortunately, there's a huge disparity in infant mortality. Black non-Hispanic infants are 2.5 times more likely to die than white non-Hispanic infants in Maryland. And also, if you look at over many years, there's been a consistent and sustained disparity between the maternal mortality rates by race, ethnicity. So you can see a huge gap between the number of women who are Black non-Hispanic compared to white women, and the number of deaths. This further disadvantages the Black non-Hispanic community, because think of all of those additional children raised without mothers. Most maternal deaths, many of them have already, there will be other children in the family when the mother dies, and or the baby does not die when the mother dies. So and we lose this huge benefit to a population to having mothers in there to take care of their children. So how one fares in the United States has been characterized by a racial division that begins at birth with disparities in healthcare. And this is a really important for us to dig into and understand in a very deep and profound way. It's not something that we can ignore, regardless of what our race ethnicity is. And I know as a white person myself, I've been learning more and more. I've been actively learning to be able to look deeper at why these disparities exist. And I consider it a human rights issue. I consider it a public health crisis, that in the United States, 3 to 4 times more Black women die when giving birth than white women. Several years ago, I was quoted, or a couple of years ago, I was quoted by USA Today saying that we cannot just blame the women. I thought of this when I was working in California. I kept hearing people talking about, well, the women are too fat, or the women are too sick, or they have too much high blood pressure. And I was like, every time I heard it, it really bothered me. And I thought, if this is deeper than the women, this goes beyond an individual person and their lifestyle choices. We need to examine what we're doing to contribute to these disparities, and not try to blame this on the women themselves. I'm not saying that individuals don't have their own responsibilities. What I'm saying is that they are part of a system that is leading to this disparity. So all women deserve high quality care, and when we focus on where we have evidence for why there's disparities, it improves the care for all women. So that's part of the QI effort, is to make sure that we that we track data by race, ethnicity. So we make sure that as we make improvements, that we're improving the care for everyone. And that we, and I insist at the University of Maryland, the DMP students, we have a big discussion about all of the goals. Whenever you're implementing evidence-based care, you are not done as a QI leader until 100% of the population receive the evidence-based intervention. So your goal is 100%, to reach 100% of the population and not be satisfied with those that are easiest to improve. So if we think about equity and equality, this image has pretty been passed around a lot, but I think it's also very an important image. And I think a lot of, I know for myself, a lot of the ways in which I contribute to these disparities are unconscious on my part, and part of it is me looking around and not and trying to understand and trying to get a broader context, expand my view. So if you look at equality, in this image, they have all of the individuals are the same height. They're born, they're placed on different ground. Is some are on higher ground and some are on lower ground, and they all have the same number of boxes. That's equality. To have this, sorry, to have the same number of boxes. Equity is giving individuals the number of boxes they need based on how deep the ground is, how high the fence is, and what their particular needs are, so that they can see. And then you could go a step further and say justice is if you just took down the fence so everybody didn't have that barrier. This is another very popular image that shows the difference between equality and equity. Making sure everybody has a bike isn't going to meet the needs of everybody. So looking at how to make things equal for everybody by giving everybody the same isn't going to bring equity. So you need to make sure that the interventions are tailored to the needs of the particular individuals. Inequities have increased during the pandemic. Many people in Black communities or people received information that led them to believe that they were immune from COVID-19. They were not taking as much care. There's a lot of misinformation around what will keep people safe. There's also added stress and strain if you are an individual who is struggling with poverty or and having other economic pressures. Many women work on the front lines, so they hold more service-related jobs like nurses, cashiers, etc. And then also domestic violence rates have increased as people are under increased financial stress and are more socially isolated. So it's the inequities have gotten worse. During the pandemic, we had recorded, I was interviewed by Katie Couric, and she has this podcast called Next Question. And they took a while releasing it. It had planned to be released in March, but with all of the flurry of activity around the closure of so many items, this got delayed to April. But she brings in the pandemic during this, but the issues still remain. And the producer had emailed me and said, what are you doing about leading QI during a pandemic? Like, is everything on hold? And I'm like, no, we have to work even harder. The pandemic has shown the gaps to be even wider in maternity care. So we had a crisis that has only gotten worse, not better. So the urgency is even more so now than ever during a pandemic. And I know that's hard because there's so much work to be done. It's exhausting. So let me just go through now with 3 priorities. I'm going to go through vaginal birth, post-birth, and keeping moms and babies together. And with the keeping moms and babies together, I'll go over QI run charts to just kind of help you all through this work that you're doing to improve outcomes. Because I know every day you get up to go to work, and to bring about better outcomes. And so I want you to leave with some additional tools, not just understanding that there's a problem, but how do you really address that problem? How do you work on that? And so I'm going to go through some key tips around that. I'm sure you're all familiar now with the maternal bundles, and these are very rich in resources and insights. And if you have only looked at the bundle itself, I highly recommend that you look at the commentary and not just focus in on the bundle. But I won't be able to touch on all of these bundles today. There's just not time in this presentation. But you can see the three that I am going to focus in on. There are bundles around two of them. One is on safe reduction of primary cesarean birth, and the second is postpartum care basics for maternal safety. And then the third topic about keeping moms and babies together is there's been a lot of work by A1 on that. All safety bundles include information that's really important for safety in general, and particularly important during a pandemic is to hold team huddles, debrief after events, run simulation drills. So here's the safe reduction of cesarean birth bundle. It has a lot of really rich information within it. Each of the bullets are particularly packed with a lot and really focuses a lot on context. It's needed because in the United States, even before the pandemic, we had overall, our C-section rates were too high. And you can see the states that have the highest rates. And there's also interest, we know that there's more morbidity related to high rates of C-section, and much of that morbidity is preventable for both babies and moms. I don't know if you've seen this blueprint for advancing high-value maternity care. It came out a couple of years ago, and now it's really filled with a lot of evidence-based research and information about how to support physiologic childbearing. If you did not see this, I highly recommend it. It really, I gave you the reference here. It's, again, it's just going to make your life a lot easier as people ask you questions and wondering about what are some of the strategies for reducing C-section rates. Hopefully you're all using peanut balls or spacing balls. You're turning women frequently. And then also, I think another big strategy that's been used successfully across the country is to work on increasing the use of intermittent auscultation. So freedom of movement supports vaginal birth, and it helps reduce cesarean birth. We actually created at the Institute for Perinatal Quality Improvement an online module that includes simulation, recorded simulations, and so at the end of the module, an individual will have the competency to be able to auscultate. This is now available so that, and we have many nursing schools are requiring all of their midwifery students to use this education to help them learn how to auscultate and perform intermittent auscultation. So it's a skill that isn't always emphasized or practiced enough, and I think it's definitely will help us with our efforts to reduce C-section rates in the United States. Eliminating overuse is a big priority during a pandemic, because the last thing you want is to have people, to have women have surgery that they have to recover from, while it makes them more vulnerable to getting other infections. Also, infants have more respiratory disease distress after a C-section, and breastfeeding is more challenging. It's just harder to recover from major surgery. So those are the short-term kind of pandemic-related reasons for why keep focusing in on this. This is very, very important to prioritize for your facility. And there's many hospitals that have rates of less than 20% nulliparous term singleton vertex C-section rates. So now I'm going to talk about postpartum. I do offer through the Institute for Perinatal Quality Improvement free webinars, and I did do this webinar on post-birth. One reason I wanted to focus in on post-birth education is because during a pandemic, we're discharging women home earlier. They may be more hesitant to know when to get help. They may be more hesitant to go to their doctor. So we just want to be really clear that everybody, because so many of the deaths are occurring immediately within a few days of giving birth, this is very big priority, I believe, for us to make sure this program rolls out in your hospitals if you haven't already. Just a reminder, we published several papers on, as we were creating the post-birth warning signs. This work is through A1, is owned by A1. It was done when I was the Vice President for Research, Education, and Practice at the Association of Women's Health Obstetric and Neonatal Nurses. And it was supported with a grant from the Merck for Mothers. Here's one publication where we did some baseline assessments where we were learning what was being taught, and we found that what was being taught in different hospitals by discharge was highly variable, which as a QI person, a red flag goes off that we can definitely make a difference and change that variation. For example, one kind of fun example was like, people would say, well, when I tell women if they have a blood clot, it's like the size of a plum, but not a Costco plum. So, you know, it was interesting how little consistency there was, and that's really confusing to women if they're getting very different messages. We also found that they weren't teaching all women the same information, but we have no way to predict which women are going to have a deep vein thrombosis, which women are going to, or a pulmonary embolism, or have a postpartum hemorrhage after they go home. So our point is that all women needed all of the information, and then so we put together this improving postpartum education about warning signs of maternal morbidity and mortality. Includes the handout. It includes a checklist, a discharge education checklist, and it goes through all of the things we created in our pilot project. The program then, as I said, includes this post-birth discharge education checklist. We went through each of the key topics, and I know A1 has done some updating and has now translated a lot of this into other languages as well for the education materials. Our program also included a chart audit tool and a brief education for all of the RNs so that they would know the leading causes and know what to teach women, and there was much more consistency in what they taught. And we created the Save Your Life handout. And it's very simple. We created an acronym. I like acronyms. I think they're helpful for people to remember a lot of complex information. And so post-birth, post is the call 911 symptoms. Birth is the urgent, you need to seek care now. It's a simple one-pager. I don't know if you want to chat in, if you're using this and how that's going for you. I'd love to hear about that if any of the hospitals in Maryland are using this information, this material. We actually had one of the women who I was working with, she's a nurse actually, her daughter had some symptoms, and she was saved because of this handout, as her mother believes, because at first the mother was thinking that her daughter was overreacting when she said her breathing was off and that she had palpitations. And so anyway, the daughters had been given this post-birth warning sign, Save Your Life handout, and she went and took it off her fridge and handed it to her mother and said, no, I'm having difficulty breathing, and so I need to go to the hospital. That's what this says. This handout told me I have to go. She got there and she had a pulmonary embolism. And her mother, as a nurse, actually an OB nurse, was I had met her in another meeting, and she was telling me, I mean, we both just started to cry. It was because her daughter could have so easily died. And there's also one of the nurses at one of the hospitals down in Georgia was teaching this. Then she had a baby, and she was like, she'd been teaching post-birth warning signs, and then she tried to talk herself out of what her symptoms meant. And she eventually like, okay, I've been teaching this to all the women. If you have these symptoms, you need to go to the hospital. She went, and she also had deep vein thrombosis that they diagnosed in her legs. So before it went into her lungs, she was able to get that caught. It's, you know, we don't know, and women hesitate. Women hesitate to go. They don't want to be, and I think it's only going to be worse in a pandemic. So we also did a survey, a national study of A1 nurses who identified themselves as postpartum nurses, and found that they were not very knowledgeable about post-birth warning signs. In fact, many of the nurses at that time actually didn't know there was a rise in maternal mortality. They didn't think maternal mortality rates had gone up. So the good news, well, it got a lot of national attention. This one got on NPR because it was right around the time that Renee Montaigne and Nina Martin were doing their big Lost Mothers series that helped bring attention to the issue around maternal mortality in the United States and the crisis we're facing. But basically, the good news is that there's a lot of opportunities here. So I really feel like if every woman goes home from a hospital, does get discharge education, we should improve how that discharge education goes. And in particular, as I said before, during a pandemic. And not only do the RNs need to have this, know this information, so do the all of the clinicians. It needs to be taught in a way that is very easy for women to remember. So I do, if you, again, these are the emergency warning signs. Make sure all women giving birth know that this is an emergency. We were like, do we really have to put seizures in there? One people would call 911 with seizures, but it helped us with our acronyms. So anyway, but, and it's also important to point out. So anyway, and then the birth, and again, some of this has been tweaked by A1, has been made they've done a few adjustments to this since then. So to get the latest and learn more about the post-birth program, I highly recommend you go to a1.org and learn more about it. And I see that at Mercy Medical Center, they're using postpartum birth warning signs on there, and they've had good success. So you've got in-state experts here that can help you know how to roll this program out in your facilities. So now I'm going to type, and I saw the other comment, but I'm going to get to that in the Q&A, Kendra, if you don't mind your question. But if anyone wants to chat in and answer to her, that would be great. But let's talk about that as in the Q&A. So keeping moms and babies together, this has been a big controversy, I think, in the United States with the COVID-19. We've got, actually, it's really one of these hard situations where we've got the CDC's recommendation being a little more, being a little different than the AAP. So I don't know if this is an issue at your hospitals or not, but this has led some women to make the decision to not give birth in a hospital. They heard that their babies were taken from them. And we're talking about women who have symptoms or confirmed COVID-19. And so the CDC says that that they should wash their hands before touching their baby, wear a face mask if possible while feeding, when the baby's feeding at the breast, and then wash their hands before touching the pump or the bottle. So, oh dear, I'm trying to move my chat. So chat box, 1 second, here we go. The AAP guidelines recommend for women, not all women, but does recommend some separation of moms and babies. And there are hospitals that have taken this very seriously and separating moms and babies. And then a day later or a day and a half later, sending moms and babies home together that were separated. So then the mom and baby didn't have any of the benefits of being together, and they also didn't have time to be taught together, to have the mother practice with the staff and the nurses helping support breastfeeding and other care practices. The other piece of this is there's so much research to show the benefits of keeping moms and babies together. So this gets back to my earlier point about being careful we not cause more harm than good by trying to prevent infection. And I know one physician I was talking to about this, I was on an expert panel for another state who was looking at putting out their state recommendations, and his point was, well, we do this for tuberculosis, and my point was, well, with tuberculosis, we know for sure that all healthcare workers aren't spreading tuberculosis. They've all been tested. With COVID-19, it's so pervasive, we don't know whether the people who are taking this adds a lot of different people to the mix of who could possibly be shedding the virus asymptomatic. And so there's so much we don't know. Like, I feel like there's just a lot of caution we need to do around this, around how to handle this. So, so I think, oh, I hear. So this led me to thinking about how this is a perfect opportunity for QI, right? So we need to track at a minimum what's happening, because you may have clinicians at your facility who are requiring their babies and moms be separated and others who aren't. So I'd love to have you chat in and just tell me what's happening real time in your state. I know this is varying in different places. But at a minimum, we need to be thinking about how to collect our data. So for the next few minutes of the presentation before Q&A, I'm just going to go over some real quick tips around tracking our data. First off, track it by race, ethnicity. You want to look at structure, process, and outcome data. And so here's some examples of what could be some structured data. Process data here would be skin to skin. Did it happen? How long did it happen? So here's an example. So if you have the keep moms and babies together is your goal, because you want to improve bonding and breastfeeding, then you could look at structure measures, you can look at process measures, and I gave a couple of examples. A1, when I was there, I led an expert panel who helped create and specify some process measures related to skin, and so I'll go over that in just a minute, where to find those specified measures. You can use PDSA cycles or MAPIT cycles, or in Maryland, I know the University of Maryland medical system uses IMPROVE, whichever process model to help you do multiple cycles of improvement. Then you would use your data to help track changes in structures and whether you made changes in processes and whether those actually led to the outcomes that you're trying to do. Yeah, so Rhonda typed in that there's been significant source of tension around the skin to skin. We recommend separation for fear of newborn infection, but recognize we may be creating harm with unclear benefit. Yeah, so thank you, Rhonda, for sharing that. It's very challenging when you have two major organizations that are setting slightly different, some different messages. It really makes some confusion at the front lines. So if we're thinking about what data to collect, first off, I think it's just important for us to be able to have data to show what we're actually doing. And so thinking about sample sizes, all is always best, but that's not always practical. So you can, 30 charts in a month is usually sufficient for a QI effort. And you may want to track your process daily, by shift, by week, by month. It will help you start to figure out what's going on, or by provider type. As clinicians, you can just track your own data, like, because you may have one clinician that's saying not to separate and one who is. So kind of just tracking. And be sure to do by race, ethnicity. So I'm going to just give an example. So you would just do a simple denominator. You want to know the number of full-term babies greater than 37 weeks that are healthy, meaning they weren't admitted to an ICU, That's your denominator. Those are all the babies that you want to track to see whether they're put skin to skin or not. And then these are the numerator statements. Denominator statements were created by A1, and so they defined, or I should say the expert panel, which I helped lead, defined immediate as within 5 minutes and continuous within 60 minutes. We published recently our feasibility testing of this measure, and it has a lot of detail in it. So, and here's the algorithm. I know it's hard to see this, but you don't have to recreate the wheel here. You can just look and see how to do this. One of the first steps would be to change your EHR so that you could have start and stop times. Now, nurses sometimes have talked about, well, that's very challenging. How do I get someone to chart that? But I have to say, of all if you think of skin to skin as a medication, it has more long-term effects than any other medication that is given or any other treatment that is given during immediate after birth. So it will have, there's research that even shows it can decrease abandonment in some communities. So, I mean, it's amazing. And so we spend hours documenting medications. This is one of the interventions, one of the treatments we can give that also is very highly evidence-based. So, so it's worth changing your EHR to be able to track this. And we found that several hospitals in our sample did have their EHRs configured so they could track time on, time off, and be able to get a cumulative time for skin to skin. And so that would be a great place to begin and start to look at how you track that. If we go to this example, we look at on Monday, you could look at a particular shift, you could look at the full day. 5 infants were placed skin to skin, and 10 infants were born, 10 babies greater than 37 weeks. So 5 out of 10, you've got 50%. And then let's say, like this is just an example, let's say that 5 of the babies were born to white women and 5 babies were born to black women, but 0% of the babies born to black women were placed skin to skin. That's an important QI finding. And I have to say, one of the hospitals that went through the Speak Up program said that they had not been tracking their morbidity and mortality data by race, ethnicity, and after leaving the training had started to do that. And during COVID-19, started tracking their morbidity, mortality data by race, ethnicity, and were shocked to find out how that all of the COVID-19 cases were among Black women at their hospital, COVID positive cases. This is a major medical center, which led them to more conversations around why that was the case, which helped the public health department to have that real-time, real life information that then looking at the community where those women were coming from and the situations of where they were living that were not giving them, protecting them well enough. So you also want to use run charts because you want to track your data over time. And I think this is really critical for getting a view of what's going on. And so I was so thrilled when I like to make things easy for myself. And I was thrilled when I ran across this open access Excel template. And here's the link, and here's how you here's what I even point to it. You just have to scroll down on the page and you can download this template. We're teaching all of our DMP students at the University of Maryland are using run charts in their DMP projects, and they use this tool. So so you would do your numerator denominator and put in the percent here under value. And then this tool just automatically adjusts. And I would love to go over, oh, somebody want to see the page again? That page? I don't know if that's the page, Rhonda, you want it. But I think this is all being recorded. So you can go back to this whenever you would like. So then I'm just showing you in this example is you put in the value, put in the week, the time that you're actually observing, and you put in the, you would put in the name. So you would type in what the labels and in this case I wrote in the word example. So that's the word you see at the top of the chart. And then you can see the 30. The chart will automatically, it's real time populates as you put in the numbers. So again, you would put in the week, the date of observation, the goal. What did I say at the beginning? Our goal is 100%. So you don't want to set a goal for less than 100%. So you want to see that goal. You can have benchmarks to say by this date we're going to achieve 80%, but you're not done until you get 100%. And then the median is automatically calculated with this tool, which is so fantastic. And you put in the values. So you can see the median is there. Now I put in a few additional numbers now. And this one has 0, so the run chart doesn't show anything, but it has a lot of dates in it, so you see that. And this example, I just put data up and down all over the place so you could see how dynamic this tool is, and the median adjusts, and it's so much fun. Then you just highlight it. You've got this really cool run chart that you can put in on a bulletin board. You can post in a PowerPoint. You can then show your data over time. And in this case, you can see what I put up here at the vertical axis, percent immediate skin to skin wearing a mask, and then the number of healthy moms with symptoms who is the group. In this case, you could say, okay, of all the moms with symptoms, how many are placed to skin, or you could look at just all healthy babies. There's a lot of great, I know that this is a fast overview. I don't have time to, we're not in person, but so I get this whiteboard, these quality improvement whiteboard by the IHI is just also a gold mine. These, you can see how short, these are 7-minute little videos, and they have a video, 2 videos on run charts. So they go through all of this in much more detail. I'm just giving you a highlight. So in the last few minutes, I just want to point out the Institute for Perinatal Quality Improvement Speak Up program. This is the acronym that goes along with the mnemonic Speak Up. So Speak Up is more than verbalizing, it's also doing QI. And the Speak Up program is a little different than the other implicit, explicit bias trainings that are out there, because it combines the training around implicit explicit bias with creating action plans and using QI methods. If you want to learn more about the program, here's an image from our website where you can go and access the page and learn more about it. And then we also do have some upcoming events, which actually I think, even though there's one scheduled for Texas in February and one scheduled for Memphis in March, I'm not sure we're going to be doing those in person. I'm pretty sure we'll probably move those virtual, which will make it easier for people across the country to join us. Those are open. We have other state-based ones that are closed that are only for state individuals within a certain state. We've also just released, and we have 2 more modules. These are self-paced learning modules, so you could have a whole team go through them. This one goes over trends and racial disparities in maternal mortality and morbidity. It comes with CNE or non-CNE to keep the price lower for the non-CNE. It's by community workers, anyone who you interact with who you want to kind of get educated on trends and disparities. And you can get that through the store. So, and if you have questions, if you wanted a group, wanted to look at this preview to see if you wanted it for a group, let me know. I'm happy to share, happy to let you have a free preview. We also have PQI profiles. These are some recent profiles that have just come up. We have others that highlight cool things that people are doing across the country. If you are doing some really neat stuff, you can join us as a basic member, put it on our map, and that's how we identify people that we profile. We also have free webinar series, and I want to point out the webinar series we did yesterday actually was on reducing Ohio's preterm birth rates, and she went over her QI tools that she used as the director of Medicaid. That's Dr. Mary Applegate from Ohio, director of Medicaid, uses QI now, run charts now for tracking their efforts through their real-time efforts to reduce preterm birth rates. So if you have any questions, just to remind you all, Speak Up champions are needed now more than ever, and that QI does indeed save lives. So it's very, and it is our ethical responsibility to participate and lead QI, and I think it's needed now more than ever. Any questions or comments that you want to me privately, you can send an email. Now let's open up the time for some more Q&A, and I'd love to have you chat in some questions or comments that you have based on what I presented today, or other questions on your mind.
Thank you. Resources that Maryland hospitals can use to continue their quality improvement efforts during COVID-19. So I think some early questions came in the Q&A box, in addition to the chat box. So the first one was from Lio George, which is, how do we make sure we are improving QI with telemedicine and not decreasing quality? A very timely question.
Oh my gosh, yes. And I think it's pretty hard because we haven't even caught up to how to get those paid for, which often in QI efforts from like a big state, using claims data to help you kind of look for ways to look for some, like, trends that would help you. I think on an individual level or at a hospital level, I think one of the first things is whether there's utilization. So that's one place to begin. Are people actually getting seen? And then if not, why not? Like, has utilization of prenatal care gone down? There's always been efforts, even with utilization data, we know that the variation in quality has been huge around prenatal care, and there's also efforts around group prenatal care, which obviously are now affected by COVID-19. So I think identifying what you feel are some key markers of quality. For example, you could have, like, are people getting their their blood glucose levels tested early enough and at the right time? Do you have problem lists? Is there communication between the prenatal and the inpatient side? And if not, where's those gaps? Those would be some really key questions that I would have right now. I think another big key question is around testing. So sometimes, like, what to do if somebody was tested a week ago, we know that test would not necessarily be effective. And I'd be curious if you all are doing universal testing on admission to labor rooms, even if they were tested previously. So if you wanted to chat that in for each other, I know that in Massachusetts, pretty much all the hospitals now are doing universal testing on admission. So anyway, I would like, if you have ideas, I'd love to have you chat those into things that I didn't mention. Some of you may have actual QI projects you're doing right now that would be helpful to others. Another question?
Yeah, the next question that came in is from Kendra Ellison. Has anyone developed an alternate to running the simulation drills in the presence of maintaining social distancing requirements?
Yeah, so that was to the group, and I would love to have you all put that in there. I do not know of anyone who has created alternatives to running simulation drills. I do the online simulation for the intermittent auscultation. That, of course, is as social distanced as you can be. So in that case, but that's not a drill. Years ago, out in California, there was a company that was doing tabletop simulation drills and had thought and took the algorithm for obstetric hemorrhage and was building that into their tabletop drills, and using people on their own computers doing a whole team simulation, which is super cool. And I know that has now evolved to be much more sophisticated. And so I do know that there are online approaches to building teams and doing simulation. At the University of Maryland School of Nursing, we do standardized patient drills, and we are looking at also just limiting the number of people who practice in those drills, and also thinking and then doing case scenarios. So like basically what happens if, and people going down different pathways, and some professional organizations have that. But I'll be quiet now. If any of you have some good examples to share with each other, that would be fantastic. I'd love to learn more about it.
Let's invite people to add those to the chat box if they have experience that they can share. The next question came from Rhoda Raji. We've been aggressive with trying to reduce hypertension-related disease, and our readmission rates have risen significantly related to postpartum magnesium administration, creating financial consequences. Suggestions for how to manage postpartum hypertension safely without increasing readmission rates, or how to convince hospital administrators not to see these readmissions negatively when it has monetary consequences.
Yeah, I think the first step is first to educate the financial people that this is good news. These might have been deaths, and so helping them understand nationally. And I also have been really careful when I talk to people about readmission rates, not to see that as that's not your goal. Your goal is reducing morbidity and mortality. Readmission rates for near-miss women in a near-miss situation is ideal. In fact, that's the other, also with hemorrhage, I had people who have gotten confused and used the number of blood products as like the outcome, and it's not. I mean, we need to increase blood products, not decrease them, in order to save lives. So that's the first step, is just really helping educate them. And I've been saying it nationally, and others have been saying that as well nationally, to try to help insurance companies understand that. And I think just continually, as you all talk about this, to make sure you bring that point home. The other piece is I would look at the whether they're being discharged too early. I bring that up because in the deaths that I've reviewed, I reviewed 3 years worth of deaths in California. I also have participated in a lot of other case reviews, and a lot of and then in our pilot projects for post-birth warning signs, there were a lot of women who were not necessarily being discharged with stable vital signs, and were not being discharged with appropriate postpartum follow-up. And so ACOG has come out with a huge effort to increase have women receive earlier postpartum care. So if you haven't implemented the ACOG guidelines, which came out really not that far before the pandemic, and so I think they might have gotten buried in people's priority list, but it's a very excellent recommendations, and it's a lot of work to figure out how to get women, especially during a pandemic, into earlier postpartum visits when we weren't doing postpartum visits very well to begin with. And then also making sure that the hospital is the safety net, but we just have to make sure that if women are, we're glad for that. We want to encourage that. So yeah, keep track of your data too, and that will be helpful for ongoing conversations for the state, because I congratulate you for even knowing that you have increased your rates, because I have to say the data is pretty poor in a lot of hospitals, so congratulations. But I would also look at the social factors, the social determinants that might be connected to those readmission rates, and are they getting their medications, and all of those different components that might be affecting those readmission rates. So yeah, great question.
We have one chat that addresses the simulation question from Catherine Giancola, that they've been continuing with shoulder dystocia team simulation with education in a larger space that allows for social distancing. And the simulations are in small groups with all staff wearing masks and face shields.
Great. That's really great. Thank you, Catherine, for pointing that out.
And then we have another question from Rhoda, which is, who acquires the kind of data that you showed? I think maybe this is the run chart data pulled out of the EHR database.
Yeah, that's a really good question. Actually, there are well-resourced hospitals where they have a team, a QI team that does collect data. I did mention that there needs to be, as much as possible, electronic, changing the electronic health record so data collection burdens are reduced. But I think everyone has that responsibility, and sometimes when you say everyone, that means no one. So I recognize, like, well, who's the lead? Who's going to make sure that happens? And I have to say that often is the nurses to often take that leadership role and pull that team together, especially in obstetrics where many of the physicians are not on staff. But I do think it is important to explain to the administration that work and why it's needed, and utilize this effort, this statewide effort, to help make the case for why resources should be allocated for this type of ongoing QI data collection, data review. I did a simple thing when I was a director of nursing. I created audits, and every month we would do audits in each of the units I supervised. I created a binder, and in the binder was the audit tool for that particular month. And I assigned charge nurses on different shifts and it rotated, and they had an entire month to randomly select charts and to fill in their forms. So it sat at the desk, and that was part of their job responsibility, was to review the charts, and it helped them have insights into the type of care that was being given, and also then being clear that everybody knew what the QI priorities were for that particular unit. And I had 7 different specialty units, the NICU, the postpartum, 2 postpartum units in 2 different hospitals, and the labor room. And then I would post those results every month. I had basically run charts that I would create and post so that people saw what was going on. And yeah, so that was one way that it worked for me. That's very old school, very paper driven, but that was at least a place to begin. I've had administrative assistants who go through logbooks to gather key data. So your system, it depends on your system a lot, but it's still, that's why I pointed out that this is an ethical responsibility that we all have in order to participate in QI, and it's not been one that we all were taught necessarily how to do, and it hasn't been one that's been well resourced. So that's a lot of work that needs to happen on multiple levels.
Okay, it looks like we've reached the end of the questions that our participants had. So I want to go ahead and, oh wait, looks like we have one more that just came in from Andrea Zebran from HSCRC, who is asking about connecting with someone who's asked the question about postpartum readmission. So thank you for submitting your information. We can work with you to help try and make that introduction.
Oh, I love what Andrea said about the considered planned admissions. That's a way to get it out of that, out of the numbers. I mean, the Medicaid, Medicaid is working hard on cutting down readmission rates, and so how to track it. That's a really good suggestion, Andrea.
Okay, great. So thank you everyone for joining for this webinar today, for your efforts for quality improvement for mothers in Maryland. And thank you very much, Deborah, for sharing your expertise with us to help support everyone in their work.
Oh, I'm so excited to have been with you all. Thank you for inviting me, and be well.
Thank you. And as a reminder, the webinar will be posted on the MD Mom website, so you can review it again and share it with your colleagues. And we have additional webinars coming up in the series, about one a month. So thank you again for joining us, and have a great day, everyone.